My name is Dr. Dany Barrak. I'm a surgical oncologist. I'm very excited to be talking about one of the new approaches that we started here at the clinic. A 58-year-old female patient, previously healthy, a gastroenterologist who performed her first screening colonoscopy. They saw a large polyp, or very early rectal cancer that was biopsied and proven to be an adenocarcinoma, an early stage adenocarcinoma. What we were dealing with is something called rectal cancer or rectal adenocarcinoma. Sometimes it's very difficult getting to those areas pretty low in the rectum just because of the difficult location. And usually doing surgery in the rectum is very challenging, whether it's open surgery or even minimally invasive. Usually the best option for these patients, if it's not too much of an advanced cancer, is to really avoid having to undergo a resection and trying to remove these tumors endoscopically. That means with no incisions and from the inside of the colon wall. But this sometimes becomes challenging because, of course, we don't have the necessary instruments that can go all the way up and down the anal canal, and so that's really when the robot became very helpful, and we wanted to kind of really try this new approach here at Watson Clinic. I don't even like to call it robotic surgery. I like to call it robotic assisted surgery because I want to make sure that patients know that the robot is not independent. The robot will not do anything without us telling it what to do. We kind of control all the arms of the robot, and what the robot, all it does is translates our hand movements into finer movements on the operating table. That's really all the robot does. We did the first robotic transanal excision of a rectal tumor. So the tumor was fully removed. We use margins, which is a very important thing in surgery, where we need to make sure that the tumor and a little bit of some healthy tissue around it and under it is taken with it too. So we're able to do all that, make sure the area doesn't have any bleeding, and also with a robotic instrument suture from the inside of the rectum to just make sure that that defect is closed, and that's what we did. And the patient just left within a few hours from surgery. That is very different than if we were to actually do a full, segmental resection of the colon. That requires a new connection, that requires 3 to 5 days in the hospital. They recover faster, they don't need a hospital stay, there's less chance of infection and all these things that come with it. So that's why I think, in the right situation and when we kind of screen patients adequately for this surgery, there's a lot of people that benefit from it.